Welcome to the deep dive, where we really get into the nitty-gritty, pulling out the key insights you need. Today, we're tackling a really fundamental area of health, alterations of pulmonary function. Our guide is a fantastic chapter from Understanding Pathophysiology, the 7th edition. And our mission, basically, to break down this complex stuff, help you grasp the core ideas, spot the crucial signs, and, understand the bigger picture of lung health.
That's a great summary. And this chapter really highlights how pulmonary disease isn't just about the lungs in isolation. Its symptoms often link up with other systems, especially the heart. We'll look at how things are classified, acute versus chronic, obstructive, restrictive, infectious, and what that actually means for the body.
Okay, let's jump in. We'll start with the most common ways our bodies kind of wave a red flag, signaling something's up with our breathing. What are those key signs that usually pop up first?
Well, the big two are definitely dyspnea and cough. But we also see things like abnormal sputum, hemoptysis, strange breathing patterns, problems like hypoventilation, hyperventilation, and then more visible signs like cyanosis, clubbing, and different kinds of chest pain.
Okay, let's unpack dyspnea first, that subjective feeling, like you said, of breathlessness. What's interesting about it?
What's really striking, I think, is that how bad someone feels, it doesn't always line up neatly with how bad the actual disease is. It's truly personal. Some call it air hunger, others shortness of breath. And it can stem from widespread lung damage, issues with ventilation, or interestingly, even psychological things like anxiety. When it gets more severe, you might actually see signs like nostrils flaring or someone using extra muscles just to get air in.
And it comes in different types, right? Like with exertion or lying down.
Exactly. There's dyspnea on exertion, which is pretty common. Then orthopnea, that's discomfort specifically when lying flat. And PND, paroxysmal nocturnal dyspnea. That's the really alarming one where you wake up suddenly gasping for air at night.
Okay, now cough, that's a reflex, but a vital one. How does it work, and what clues does it give us?
Right, coughing is crucial. It's basically an explosive exhale to clear the airways, triggered by irritant receptors. But here's a key detail. The very deepest parts of the airways, the tiny bronchioles and alveoli, they don't have many of these receptors. So you can actually have secretions building up way down deep without triggering a cough, which can be, quite dangerous.
So a lack of cough doesn't always mean clear lungs.
Precisely. And we classify coughs too. Acute coughs usually resolve in a couple weeks. Think common cold, acute bronchitis. Chronic cough, though, the persistent kind, that often points to things like postnasal drip, asthma, GERD, or particularly in smokers, chronic bronchitis, or even lung cancer. And if someone can't cough effectively, that really increases their risk for pneumonia.
Beyond just the cough, what about the stuff being coughed up the sputum?
Yes, sputum. Changes in its amount, its color, its consistency. These are really valuable diagnostic clues. It might be clear and foamy or thick and yellow-green, indicating pus or even bloody.
And speaking of bloody, hemoptysis, coughing up blood. That sounds serious. How do we know it's not, say, blood from the stomach?
Good question. Hemoptysis is typically bright red blood. It might look frothy. It's alkaline, and it's mixed with sputum. That usually points to some damage in the airways or lung tissue itself, maybe from infection like pneumonia or TB or inflammation, or even a tumor or pulmonary embolism. Vomited blood, hematemesis that's usually darker, acidic, and often mixed with food particles. Very different picture.
Okay. Our bodies are amazing at adapting, and breathing patterns can change quite dramatically. What are some of the key abnormal patterns we should know?
Yeah, normal breathing, eupnea, is just rhythmic, effortless. But when things go wrong, we see changes. There's Kussmaul respiration, think deep, rapid breaths, like hypercapnia. You often see that with strenuous exercise or metabolic acidosis. Labored breathing indicates some kind of airway obstruction, and it looks different depending if it's a large or small airway issue. Restricted breathing, maybe from something like pulmonary fibrosis making the lungs stiff, that leads to small, fast breaths, dyspnea.
And there are even more severe patterns.
Yes, like gasping respirations, often seen in shock, or when the brain isn't getting enough oxygen. And Cheyne-Stokes respirations, those cycles of deep breathing, then shallow breathing, then a pause, then repeat. That's often linked to poor blood flow to the brainstem or neurological issues. Even anxiety can cause sighing breaths.
Let's focus on two really critical states related to gas exchange, hypoventilation and hyperventilation.
Right, these are crucial. Hypoventilation is basically inadequate alveolar ventilation. Your body just isn't removing CO2 fast enough to keep up with production. And the really interesting, or maybe dangerous thing here, is that someone's breathing might look okay, quite normal even.
But their CO2 is climbing.
Exactly. Arterial CO2 goes above 34 millimeter Hg, that's hypercapnia, and it leads straight to respiratory acidosis. It can be caused by anything that depresses the respiratory center, like drugs or neuromuscular diseases, chest wall problems, airway obstruction. High CO2 can also affect the brain, causing drowsiness due to vasodilation.
Okay, so that's too little ventilation. What about too much hyperventilation?
Hyperventilation is the opposite. Alveolar ventilation actually exceeds what the body needs metabolically. So you blow off CO2 too fast, dropping arterial levels below 36 millimeter Hg hypocapnia and causing respiratory alkalosis. You often see this with severe anxiety, head injuries, or intense pain. For both hypo and hyperventilation, you really need blood gas analysis to know what's truly going on with gas exchange.
Moving to signs we can actually see. Cyanosis, that bluish discoloration.
Yes, cyanosis. It's due to increased amounts of desaturated hemoglobin in the blood. Peripheral cyanosis, maybe in the nail beds, usually points to poor circulation out in the limbs. Central cyanosis, which you'd see in the lips or inside the mouth, that indicates a deeper problem, decreased oxygenation of arterial blood.
But is it a reliable sign?
That's the key point. Not always. It's actually considered an insensitive indicator of respiratory failure. Why? Well, someone with severe anemia might not look blue, even if they're very low on oxygen. And someone with polycythemia, too many red blood cells, might look cyanotic even with decent oxygen levels. So it's a sign, but often a late and unreliable one.
And what about clubbing, that distinctive change in the fingers and toes?
Clubbing. Okay, picture the very end segment of your finger or toe becoming sort of bulbous, rounded, almost like the end of a tiny drumstick. It's usually painless, and we grade its severity. It's strongly associated with conditions causing chronic low oxygen levels, like bronchiectasis or cystic fibrosis. The exact mechanism isn't fully known, but a leading theory involves platelet clumps getting into the systemic circulation and releasing growth factors that cause this change in the nail beds. It's a pretty striking sign when you see it, but unfortunately, it's rarely reversible.
Chest pain always makes people think heart attack, but the lungs can cause pain too, right?
Absolutely. Pulmonary disorders cause specific types of pain. Pleural pain, or pleurodynia, is typically sharp, stabbing, and worse when you breathe in. You might even hear a pleural friction rub a sort of grating sound. Pain from the trachea or bronchi feels more central, often worse after a bout of coughing. Pulmonary hypertension can cause a kind of exercise-induced chest pain that really mimics angina, and of course there's simple chest wall pain, muscular or from the ribs, maybe from coughing too hard or an injury.
Okay, let's shift now to the conditions caused by these pulmonary issues. Starting back with hypercapnia.
Right, hypercapnia, that elevated CO2 in the arterial blood we talked about. The fundamental cause is always alveolar hypoventilation. If you imagine figure 29.2, it shows this relationship clearly. Decreased ventilation leads directly to CO2 buildup, which lowers pH, causing acidosis. The causes are diverse. Anything from drug-induced respiratory depression, central nervous system diseases, spinal cord problems, neuromuscular diseases like myasthenia gravis, major chest injuries, airway obstruction, or just the increased work of breathing in diseases like emphysema. And remember, those high CO2 levels can cause cerebral vasodilation, leading to drowsiness or even coma, and can trigger heart rhythm problems.
And the flip side, hypoxemia, low oxygen in the arterial blood. Different from hypoxia, which is low oxygen in the tissues themselves.
Exactly, a key distinction. Hypoxemia results from problems in one of three main areas of oxygenation. First, oxygen delivery to the alveoli affected by overall ventilation and the amount of oxygen you breathe in. Second, diffusion of oxygen from the alveoli into the blood. This depends on the VQ match and the health of that alveolo-capillary membrane. And third, perfusion, just getting enough blood flow through the pulmonary capillaries.
And you said the most common cause is VQ mismatch.
By far. So picture figure 29.3, which illustrates these VQ abnormalities. You can have inadequate ventilation of areas that are getting blood flow that's like a shunt. Blood flows past alveoli that aren't getting enough air, so it doesn't pick up oxygen. Think asthma or pulmonary edema. Or you can have the opposite. Poor perfusion of areas that are getting air that's wasted ventilation or alveolar dead space. Air goes in and out, but there's no blood flow to pick up the oxygen. The classic example is a pulmonary embolus blocking blood flow. Both lead to hypoxemia.
What are the consequences for the body when hypoxemia sets in?
Well, widespread tissue dysfunction is the main one. If it's severe and prolonged, you can get actual organ damage or infarction. It also triggers something called hypoxic pulmonary vasoconstriction. The blood vessels in the lungs constrict in response to low oxygen. This actually increases the pressure in the pulmonary arteries, putting a huge strain on the right side of the heart, which can eventually lead to right heart failure, what we call cor pulmonale. Clinically, you might see cyanosis, confusion, a racing heart. maybe decreased urine output as the kidneys feel the effects.
And when gas exchange totally fails, we get acute respiratory failure. Define that for us.
Okay, acute respiratory failure. It's formally defined by blood gas numbers. Arterial oxygen, PO2, of 60 millimeter Hg or less, that's hypoxemic failure. Or arterial carbon dioxide, PaO2, of 50 millimeter Hg or more, with a pH of 7.25 or lower, that's hypercapnic failure. Or often, a combination of both. It can happen from direct lung injury, like pneumonia or ARDS, or indirectly from problems elsewhere, like the brain or heart failing. Hypercapnic failure means ventilation isn't adequate, needing support like a ventilator. Hypoxemic failure needs supplemental oxygen.
And you mentioned post-op patients being high risk.
Definitely, especially those who smoke, are obese, or already have lung, heart, or neurological issues. This is why prevention is so critical after surgery.
Things like deep breathing exercises, getting patients walking early, using those incentive spirometers.
Exactly, all aimed at keeping the lungs open and clear. Severe cases might need mechanical ventilation or even ECMO, that external oxygenation machine.
Okay, let's broaden the view beyond just the lung tissue. The chest wall and the pleura, the lining around the lungs, are crucial too. How can the chest wall itself cause problems?
Right, the chest wall needs to move freely for breathing. Conditions like severe obesity, a badly curved spine like kyphoscoliosis, neuromuscular diseases that weaken the muscles like polio or muscular dystrophy, or even just significant pain from an injury can restrict how much the chest wall can expand. This increases the work of breathing, shrinks the tidal volume, and can lead to hypoventilation and hypercapnia.
And the text gives that really vivid example, flail chest.
Ah, yes, flail chest. So imagine figure 29.4. You have multiple rib fractures, maybe the sternum too, in a way that decaches a segment of the chest wall. It's no longer stable. So when the person tries to inhale, the negative pressure inside the chest actually sucks that loose segment inward while the rest of the chest expands.
Paradoxical motion.
Exactly. And then when they exhale, it pushes outward. This completely disrupts normal airflow mechanics, making ventilation very inefficient. It can rapidly lead to hypercapnic respiratory failure. It's a serious trauma injury.
Okay, and what about problems within the pleural space itself, that potential space between the lung and the chest wall?
Right, normally there's just a tiny bit of lubricating fluid there and negative pressure. But things can go wrong. Pneumothorax is when air gets into that pleural space. It could be from a rupture on the lung surface, the visceral pleura, or through the chest wall, the parietal pleura. This air destroys that crucial negative pressure, and the lung's natural elasticity causes it to recoil and collapse inward towards the hilum. Figure 29.5 shows this, the collapsed lung, air filling the space.
Where does the air come from?
It can be primary or spontaneous, happening out of the blue, often in young, healthy men due to rupture of tiny blebs on the lung surface. It can be secondary, caused by chest trauma, or underlying lung disease like emphysema breaking down tissue. Or it can be iatrogenic, caused by a medical procedure like inserting a central line.
And there are different types based on how the air behaves.
Yes, crucially, an open or communicating pneumothorax means there's an opening, maybe from a wound, that lets air move in and out of the pleural space with breathing. The lung partially collapses. But tension pneumothorax is the really dangerous one. Here, the tissue rupture acts like a one-way valve. Air gets in during inspiration, but can't get out during expiration.
So pressure builds up.
Dramatically. It keeps building, collapsing the lung completely, and then pushing the entire mediastinum, the heart, trachea, great vessels, over to the opposite side. This compresses the good lung and obstructs blood flow back to the heart. It's a true medical emergency, causing severe hypoxemia, tracheal deviation away from the affected side, and hypotension. You have to relieve that pressure immediately.
So pneumothorax is air. What about pleural effusion fluid in that space?
Right, pleural effusion is an accumulation of fluid in the pleural space. Normally, tiny amounts of fluid are made and reabsorbed, keeping the surfaces lubricated. Effusion means too much fluid is accumulating. It usually comes from blood vessels or lymphatic vessels just under the pleura. We look at the type of fluid to figure out the cause.
What are the main types? The text mentions a table, table 29.1.
Yes, table 29.1 breaks it down. You have transudative effusion, that's watery fluid, low in protein. It's usually caused by increased pressure in the capillaries, like in heart failure or sometimes liver or kidney disease, pushing fluid out. Then there's exudative effusion. This fluid is thick, rich in cells and protein. It indicates inflammation or infection, maybe malignancy, damaging the capillaries and making them leaky. And then there are specific types. Empyema is frankly pus in this space, usually from infection. Hemothorax is blood, often from trauma. Chylothorax is milky lymphatic fluid. from lymphatic obstruction.
And what does this fluid buildup do?
Well, a small effusion might not cause many symptoms, but large ones compress the underlying lung, making it hard to breathe, causing dyspnea. It impairs ventilation on that side and can cause pleural pain. When listening to the chest, you'd hear decreased or absent breath sounds over the effusion, and it would sound dull if you percuss or tap on the chest wall there.
You mentioned empyema-infected fluid.
Exactly. Empyema is pus collecting in the pleural space. It's often a complication of pneumonia or sometimes surgery or trauma. More common in older adults and kids. Common bacteria like Staph aureus or E. coli might be involved. It presents like a severe infection. Cyanosis, fever, rapid heart rate, cough, and pleural pain. Treatment needs antibiotics and usually draining the pus.
Okay, let's shift focus inward now to diseases of the lung tissue itself, starting with restrictive lung diseases. What's the defining feature here?
The key characteristic of restrictive lung diseases is decreased lung compliance. Basically, the lung tissue itself, or sometimes the chest wall, becomes stiff and less stretchable. This means it takes more effort, more pressure, to expand the lungs during inspiration. This naturally leads to dyspnea, an increased respiratory rate because people take shallower breaths, and a decreased tidal volume. The lungs just can't fill up as much. On pulmonary function tests, you see a hallmark decrease in the forced vital capacity, FVC. And physiologically, these conditions often cause VQ mismatch and affect that alveolar-capillary membrane, leading to hypoxemia.
Let's look at some specific examples. What about aspiration?
Aspiration is when fluid or solid particles accidentally go down the wrong pipe into the lungs instead of the stomach. This often happens in people who have trouble swallowing or have a weak cough reflex, maybe due to altered consciousness, neurological problems, or even feeding tubes. The right lower lobe is anatomically the most common place for things to end up.
And the consequences can be serious.
Oh, absolutely. Aspirating large particles like food can physically block a bronchus, causing inflammation and lung collapse distal to the blockage. If acidic stomach fluid is aspirated, it causes a severe chemical pneumonitis inflammation damaging the alveolar-capillary membrane and messing up surfactant function. This makes the lungs stiff and prone to edema and further collapse. Symptoms can be sudden choking and coughing, or it might present later with fever, dyspnea, wheezing. Chronic, smaller aspirations can lead to recurrent lung infections.
Okay, then there's atelectasis. That just means lung collapse, right?
Yes, atelectasis is simply the collapse of lung tissue. It's not a disease in itself, but a consequence of something else. There are three main types. Compression atelectasis is when something outside the lung is pushing on it, like a tumor or fluid effusion. Obstructive or absorption atelectasis happens when a bronchus gets blocked, maybe by mucus or a foreign body. The air trapped in the alveoli beyond the blockage gets slowly absorbed into the bloodstream, and without incoming air, the alveoli collapse. And surfactant impairment atelectasis occurs when there's not enough surfactant, that substance that keeps alveoli from collapsing at the end of expiration, seen in premature babies or ARDS.
And this happens a lot after surgery.
Very common post-operatively, yes. Patients tend to breathe shallowly because of pain. They're immobile, maybe have anesthesia effects, and secretions can pool and obstruct small airways. Atelectasis causes VQ mismatch because blood flows past collapsed, unventilated alveoli, leading to hypoxemia. Symptoms like dyspnea, cough, and fever can mimic infection. That's why prevention is key. Encouraging deep breathing, changing position, getting patients moving. The book mentions figure 29.6, the pores of Cheyne. These are tiny connections between adjacent alveoli. Deep breaths help pop open collapsed alveoli by forcing air through these collateral channels.
What about bronchiectasis? That sounds like permanent damage.
It is. Bronchiectasis is a persistent abnormal dilation or widening of the bronchi. It's usually secondary to something else that causes chronic inflammation of the airways. Often it's related to obstruction, chronic infections like cystic fibrosis or tuberculosis, or certain systemic inflammatory disorders. Basically, chronic inflammation destroys the elastic and muscular components of the bronchial walls, so they lose their shape and become permanently stretched out and floppy.
And the text highlights a classic symptom.
Yes, the hallmark is often a chronic productive cough, frequently producing large volumes of sputum that can be foul-smelling and purulent, especially in the morning. Hemoptysis, coughing up blood, is also common, as is clubbing of the fingers and toes due to the chronic hypoxemia.
And pulmonary fibrosis, that sounds like scarring.
Exactly. Pulmonary fibrosis is essentially an excessive amount of fibrous or connective tissue building up in the lung. Think of it like scar tissue forming throughout the lung parenchyma. This makes the lung incredibly stiff and difficult to ventilate low compliance again. It significantly impairs gas exchange. It can be idiopathic, IPF, meaning we don't know the cause, or it can result from healing after a lung injury, autoimmune diseases, inhaling harmful dusts like asbestos or silica over long periods, pneumoconiosis, or even radiation therapy to the chest. The key consequence is that the diffusing capacity of the alveolo-capillary membrane plummets, leading to hypoxemia.
So the main symptom would be shortness of breath, especially with activity.
Precisely. Dyspnea on exertion is usually the first and most prominent symptom. On examination, you often hear diffuse crackles during inspiration, sometimes described as sounding like Velcro ripping. Idiopathic pulmonary fibrosis, unfortunately, generally has a poor prognosis.
Our lungs are constantly exposed to what we breathe. What about inhalation disorders?
Right, inhaling harmful substances can cause a range of problems. Toxic gases like smoke, ammonia, chlorine, they can directly injure the airways, causing inflammation, swelling, edema, and potentially even triggering acute respiratory distress syndrome, or ARDS. And ironically, even too much oxygen can be harmful. Prolonged exposure to high concentrations of supplemental oxygen can cause oxygen toxicity. It leads to severe inflammation, disrupts surfactant, causes edema, and eventually fibrosis. In infants, this contributes to bronchopulmonary dysplasia.
You mentioned pneumoconiosis earlier with fibrosis.
Yes. Pneumoconiosis refers specifically to lung changes caused by inhaling inorganic dust particles, usually in occupational settings. Silica dust causes silicosis, asbestos causes asbestosis, coal dust causes coal workers' pneumoconiosis. These particles trigger chronic inflammation, scarring, fibrosis, and progressive lung function decline over many years. Symptoms like cough, dyspnea, and hypoxemia develop gradually.
And allergic reactions in the lungs.
That falls under hypersensitivity pneumonitis, also called extrinsic allergic alveolitis. It's an allergic inflammatory response in the alveoli caused by inhaling organic particles. Think mold spores from hay, farmer's lung, proteins from bird droppings, bird fancier's lung, or even wood dust. It involves lymphocytes and other inflammatory cells infiltrating the lung tissue, causing inflammation and potentially granuloma formation and fibrosis if exposure continues.
Let's talk about pulmonary edema, water in the lungs. That sounds terrifying. How does that happen?
It is a serious condition. Normally, the lungs are kept remarkably dry thanks to lymphatic drainage and a delicate balance of pressures within the tiny pulmonary capillaries. Pulmonary edema means there's excess water accumulating in the lung tissue, specifically in the interstitial space, and potentially flooding into the alveoli themselves. Figure 29.7 illustrates this pathogenesis. It shows how fluid moves from the capillaries into the interstitial space, and then, if the lymphatic system is overwhelmed, into the alveoli.
What usually causes this imbalance?
By far the most common cause is left-sided heart disease, particularly heart failure. When the left side of the heart can't pump effectively, pressure backs up into the pulmonary circulation, increasing the hydrostatic pressure inside the pulmonary capillaries. This forces fluid out into the lung tissue. Other causes include direct injury to the capillaries, making them leaky like an ARDS or from inhaling toxic gases, or problems with lymphatic drainage, although that's less common.
So what does this feel like for the person experiencing it? What are the signs?
The primary symptom is dyspnea, often severe. Hypoxemia develops because the fluid interferes with gas exchange. The work of breathing increases dramatically. Listening to the lungs, you'd likely hear inspiratory crackles, often described as sounding like cellophane crumpling, as alveoli pop open through the fluid. There might be dullness to percussion if there's a lot of fluid. In severe cases, patients might cough up pink, frothy sputum that's plasma fluid mixed with air and a bit of blood. Treatment depends entirely on the cause, often diuretics to pull off fluid, vasodilators to reduce pressure if it's heart failure, and always supplemental oxygen.
And that brings us to acute respiratory distress syndrome, ARDS. You mentioned it earlier. It sounds extremely serious.
It is. ARDS represents a severe form of acute lung inflammation and widespread injury to that delicate alveolo-capillary membrane. It's often a devastating complication seen in critically ill patients in the ICU, and it carries a high mortality rate. Sepsis and multiple trauma are probably the most common triggers.
Can you walk us through the pathophysiology? Figure 29.8 covers this.
Yes. Figure 29.8 shows the pathogenesis, focusing on the initial exudative phase. Basically, some initial lung injury, direct or indirect, damages the endothelial cells lining the capillaries and the epithelial cells lining the alveoli. This triggers a massive inflammatory response. Immune cells like neutrophils rush in, releasing inflammatory mediators. This makes the capillaries incredibly permeable, leaky. So fluid, proteins, and inflammatory cells pour out of the capillaries into the interstitial space and flood the alveoli, causing edema. At the same time, surfactant production is reduced or inactivated, leading to widespread alveolar collapse, atelectasis. The result is severe VQ mismatch, shunting, and profound hypoxemia, acute respiratory failure.
And it progresses through phases.
Right. After that initial exudative phase, first few days, there's a proliferative phase, days to weeks, where hopefully the edema starts to resolve, but fibroblasts proliferate, and thick, glassy hyaline membranes can form along the alveolar walls, creating a barrier to diffusion. If it progresses further, you enter the fibrotic phase, weeks to months, involving remodeling of the lung tissue with potentially extensive and permanent scarring, leading to long-term respiratory compromise even if the patient survives.
So, clinically, how does this progressive damage manifest?
It typically starts with worsening dyspnea and hypoxemia that, crucially, doesn't respond well to just giving more oxygen. The patient often hyperventilates initially, leading to respiratory alkalosis. But as it worsens, the work of breathing becomes exhausting, the lungs get stiffer, leading to hypoventilation, rising CO2, hypercapnia, respiratory acidosis, and ultimately full-blown respiratory failure. It can also lead to decreased cardiac output and hypotension.
This really highlights why early detection and supportive care are so vital, doesn't it?
Absolutely critical. There aren't really specific drugs to reverse ARDS itself. Management is primarily supportive, preventing further injury, maintaining oxygenation and ventilation, often requiring mechanical ventilation with specific strategies like low tidal volumes, managing fluids carefully, and treating the underlying cause, like sepsis. It's about buying time for the lungs to hopefully heal.
Okay, let's shift gears completely now to obstructive lung diseases. How are these defined differently from restrictive ones?
Obstructive diseases are all about airway obstruction that makes it difficult to get air out of the lungs. The narrowing is characteristically worse with expiration. This means it takes more force and more time to exhale. It leads to an increased work of breathing, lungs emptying slowly, significant VQ mismatch, hypoxemia, and very characteristically, air trapping where air gets stuck in the lungs, leading to hyperinflation and eventually hypercapnia.
And the unifying symptom and sign.
Dyspnea is the common symptom, yes. And wheezing, that whistling sound during breathing, especially expiration, is the classic sign. The big three here are asthma, chronic bronchitis, and emphysema. And chronic bronchitis and emphysema often occur together, and we lump them under the umbrella term chronic obstructive pulmonary disease, COPD.
Let's start with asthma. So many people are familiar with this one.
Right, asthma is now understood as a very heterogeneous disease, but the core features are chronic airway inflammation, leading to bronchial hyperresponsiveness, airways that are twitchy, airway constriction, bronchospasm, and airflow obstruction that is, importantly, usually reversible. It clearly runs in families, so there's a genetic component, but environmental factors are huge. Exposure to allergens like dust mites or pollen, air pollution, tobacco smoke, respiratory infections. Even things like obesity and GERD are now recognized as risk factors or triggers.
The text mentions the hygiene hypothesis, which is fascinating.
It is. The idea is that in very clean, modern environments, maybe we have less exposure to certain microbes early in life. This might lead our immune systems to develop in an unbalanced way, becoming more prone to allergic responses and asthma. And related to that, the Did You Know box highlights the emerging role of the lung microbiome, the community of bacteria living in our airways and influencing asthma risk and severity. It's a really active area of research.
Physiologically, what happens during an asthma attack, figures 29.9 and 29.0 seem relevant.
Okay, so figure 29.9 shows the early asthmatic response. An allergen, like pollen, binds to IgE antibodies on mast cells in the airway lining. This triggers the mast cells to degranulate, releasing a flood of inflammatory mediators, histamine, leukotrienes, prostaglandins. These mediators cause immediate effects: intense bronchospasm, smooth muscle constriction, increased capillary permeability leading to mucosal edema, swelling, and increased mucus production. Figure 29.9 shows this whole cascade. Then there's the late asthmatic response, hours later. Other inflammatory cells like eosinophils, neutrophils, and lymphocytes are recruited to the airways, prolonging the inflammation, swelling, and hyperresponsiveness.
So what does that actually look like inside the airway, figure 29.11?
Yeah, figure 29.1 gives a good visual. You see the airway wall thickened by edema and inflammatory cells, the smooth muscle layer tightly constricted, and the airway lumen clogged with thick mucus. It's easy to see how severely this obstructs airflow, especially during expiration. If this inflammation isn't treated, especially at the late phase, it can lead to permanent changes in the airway structure, airway remodeling making the asthma harder to control. Functionally, this obstruction increases airway resistance, traps air leading to hyperinflation, and makes the respiratory muscles work much harder. Initially, the person might hyperventilate, leading to low CO2, respiratory alkalosis, despite low oxygen. But if the obstruction is severe and prolonged, fatigue sets in, leading to hypoventilation, rising CO2, respiratory acidosis, which is a very dangerous sign indicating impending respiratory failure.
What does an asthma attack look and feel like then?
Typically a feeling of chest tightness or constriction, audible expiratory wheezing, dyspnea, often a non-productive cough initially, prolonged expiration time, and you might see the person using accessory muscles in their neck and chest to breathe. A severe, life-threatening attack is called status asthmaticus. Ominous signs include a silent chest where airflow is so poor you don't even hear wheezing anymore, and a high PaCO2, like over 70 millimeter Hg.
Evaluation and treatment seem key here.
Absolutely. Diagnosis relies on history, identifying triggers and allergies, and spirometry lung function tests showing decreased airflow, like FEV1, that improves significantly after using a bronchodilator, showing that reversibility. Acute attacks need immediate oxygen, inhaled short-acting beta agonists like albuterol to open the airways quickly, and often oral or IV corticosteroids to fight the inflammation. Long-term management is about avoiding triggers, patient education using peak flow meters, using inhaled corticosteroids as the mainstay anti-inflammatory, adding long-acting beta agonists if needed, sometimes leukotriene modifiers, immunotherapy for specific allergies, and newer biologic drugs like monoclonal antibodies that target IgE or specific inflammatory pathways.
Okay, let's move to COPD. This is a huge public health issue, right? Fourth leading cause of death in the U.S.
It is indeed. COPD is defined by persistent airflow limitation that is usually progressive. It's associated with an enhanced chronic inflammatory response in the airways and lungs, primarily triggered by noxious particles or gases. And the number one cause, overwhelmingly, is tobacco smoke. Other factors include occupational dusts and chemicals, air pollution, and sometimes genetic factors, most notably alpha-1 antitrypsin deficiency.
Let's break down the two main components, starting with chronic bronchitis.
Okay, chronic bronchitis, remember, is defined clinically. Hypersecretion of mucus and a chronic productive cough for at least 3 months of the year for at least 2 consecutive years.
Okay, what's happening pathologically?
Inspired irritants, mainly smoke, cause persistent inflammation in the airways. You get infiltration of neutrophils, macrophages, lymphocytes. This inflammation leads to bronchial edema, swelling, an increase in the size and number of mucus glands and goblet cells, so more mucus production, hypertrophy of the airway smooth muscle, and general airway narrowing. Ciliary function gets impaired so that thick mucus just sits there, blocking airways and providing a great environment for bacteria. Figure 29.12 shows this thickened, inflamed, mucus-filled airway. It severely compromises lung defenses, leading to frequent infections. Figure 29.33 gives a nice overview of how irritants lead to both bronchitis and emphysema.
And how does this specifically lead to the air-trapping characteristic of COPD? Figure 29.14.
Right. Figure 29.14 illustrates the mechanisms of air trapping. You have these narrowed airways and mucus plugs. During inspiration, the airways are pulled open slightly, so air can get in past the obstruction. But during expiration, which is normally passive, the airways tend to collapse slightly. With the existing narrowing in mucus, they collapse even more, trapping air behind the obstruction. This gets worse with forced expiration. This trapped air leads to hyperinflation of the lungs, decreased effective tidal volume, hypoventilation in affected areas, hypercapnia eventually, and huge mismatch causing hypoxemia.
What about the clinical picture and treatment? Table 29.2 compares bronchitis and emphysema.
Yes, table 29.2 is helpful. For chronic bronchitis, think productive cough, dyspnea, wheezing, often a barrel chest from hyperinflation, prolonged expiration, sometimes cyanosis, blue bloaters, potentially polycythemia, increased red cells due to chronic hypoxemia, and risk of core pulmonale. Prevention stopping smoking is absolutely paramount because the damage is largely irreversible. Management involves bronchodilators to open airways, sometimes mucolytics to thin mucus, anti-inflammatory agents, usually inhaled corticosteroids if exacerbations are frequent, chest physiotherapy, prompt antibiotics for infectious exacerbations, and long-term supplemental oxygen if hypoxemia is severe.
Now, emphysema, how does that differ?
Emphysema is defined structurally. It's abnormal permanent enlargement of the air spaces, distal to the terminal bronchioles, the gas exchange airways like respiratory bronchioles and alveoli. And critically, this enlargement is accompanied by destruction of their walls, without obvious widespread fibrosis. The key mechanism causing airflow limitation and pure emphysema is the loss of elastic recoil. The lung tissue loses its springiness, which normally helps hold small airways open during expiration. Without that recoil, The airways collapse easily during expiration, trapping air.
And there's that genetic link for a small percentage.
Right, about 1–3% of emphysema cases are primary emphysema, linked to that inherited deficiency of alpha-1 antitrypsin. This enzyme normally protects the lung tissue from breakdown by proteases, enzymes released by inflammatory cells. Without enough AAT, the proteases run wild and destroy lung elastin, but most emphysema is secondary, primarily caused by cigarette smoke. Smoke triggers chronic inflammation, creates an imbalance favoring proteases over antiproteases, causes oxidative stress, and promotes apoptosis, cell death of alveolar wall cells. This leads to the breakdown of elastin and destruction of alveolar septa. This merges alveoli into large, ineffective air spaces called bullae, if large, or blebs, if smaller, near the surface. Figure 29.15 shows these large bullous spaces.
So how does this wall destruction impact breathing, specifically expiration?
That loss of elastic recoil is the main problem for airflow. Expiration becomes difficult and inefficient because the airways collapse prematurely. This traps air again. Figure 29.4 applies here too, but the cause is lack of structural support rather than mucus plugs. This leads to progressive hyperinflation, flattens the diaphragm, puts respiratory muscles at a mechanical disadvantage, increases the work of breathing, and eventually leads to hypoventilation and hypercapnia, often later in the disease compared to chronic bronchitis. The destruction of alveolar walls also destroys the adjacent capillary beds, increasing pulmonary vascular resistance, leading to pulmonary hypertension and eventually cor pulmonale.
So what does life look like for someone with predominantly emphysema, table 29.2 again?
Yes, referring back to table 29.2, emphysema often presents with severe dyspnea, often minimal cough or sputum, pink puffers maintaining oxygenation longer by puffing, barrel chest, use of accessory muscles, weight loss. Diagnosis is confirmed with pulmonary function tests showing decreased FEV1 and characteristic changes in lung volumes. Treatment strategies are similar to chronic bronchitis. Smoking cessation is vital. Vaccines, flu, pneumococcal, pulmonary rehabilitation, bronchodilators, roflumilast, and anti-inflammatory might be used. Sometimes inhaled corticosteroids if there's an overlap with bronchitis or frequent exacerbations. Long-term oxygen for hypoxemia. In select cases, lung volume reduction surgery to remove the most diseased parts of the lung might be an option.
Okay, let's move into respiratory tract infections. Many of us know these all too well.
Yes, most are common upper airway infections like colds and usually self-limiting. But infections of the lower respiratory tract, the bronchi and lungs, can be much more serious, especially at the extremes of age or in people with weakened immune systems.
How does acute bronchitis differ from the chronic bronchitis we just discussed?
Acute bronchitis is typically an acute infection or inflammation of the airways, usually caused by viruses, and is generally self-limiting. The symptoms can mimic pneumonia initially, fever, cough, maybe chills, muscle aches. But the key difference is that on physical exam, you don't find signs of lung consolidation, like dullness to percussion or crackles, and a chest x-ray won't show infiltrates. The cough is often non-productive at first, then might produce some sputum. Treatment is mainly supportive, rest, fluids, humidity, maybe cough suppressants if the cough is very disruptive. Antibiotics aren't usually needed unless a bacterial cause is strongly suspected.
Now, for pneumonia, the infection in the lung tissue itself.
Right. Pneumonia is an infection of the lower respiratory tract parenchyma, the alveoli, and bronchioles. It can be caused by bacteria, viruses, fungi, protozoa, or parasites. It remains a major cause of morbidity and mortality worldwide.
The text categorizes it based on where it's acquired, right? Box 29.1.
It's exactly. We talk about community-acquired pneumonia, CAP, caught out in the community, hospital-acquired pneumonia, HAP, developing 48 hours or more after hospital admission, and ventilator-associated pneumonia, VAP, developing more than 48 hours after endotracheal intubation. Box 29.1 lists common pathogens for each. For CAP, Streptococcus pneumonia is still a major player, but also viruses, Haemophilus influenza. For HAPP, you worry more about gram-negative rods like Pseudomonas, Klebsiella, and Staph aureus, often multi-drug-resistant strains. The Did You Know box on VAP is important. It highlights how the endotracheal tube itself bypasses defenses and allows bacteria to form biofilms, making them hard to treat.
How do these microbes actually get into the lungs and cause infection? Figure 29.16.
The most common route is aspiration of tiny amounts of secretions from the oropharynx, back of the throat, that contain potential pathogens. We all do this, especially during sleep, but usually our defenses clear them out. Other routes include inhaling infectious droplets directly, or sometimes bacteria spreading through the bloodstream from an infection elsewhere. Once pathogens get past the upper airway defenses and mucociliary clearance, they encounter alveolar macrophages. If the inoculum is large, or the pathogen particularly virulent, or the host defense is impaired, the macrophages get overwhelmed. They release inflammatory cytokines, recruiting neutrophils. Figure 29.16 shows the classic example of pneumococcal pneumonia. S. pneumonia has a capsule that helps it evade phagocytosis initially. It releases toxins, triggering a massive inflammatory response. Capillaries become leaky, pouring protein-rich fluid, exudate, and red blood cells into the alveoli, leading to consolidation.
And viral pneumonia.
Viral pneumonia, often caused by influenza virus, RSV, or others, typically causes a more diffuse interstitial inflammation. It's often milder than bacterial pneumonia and self-limiting in healthy people, but it can be severe or fatal in vulnerable groups. And critically, viral infection often damages the ciliated epithelial cells lining the airways, impairing mucus clearance and setting the stage for a secondary bacterial pneumonia, which can be very dangerous.
So what are the typical signs and symptoms if someone develops pneumonia?
Often, it's preceded by an upper respiratory infection like a cold or flu. Then comes the onset of fever, chills, a cough that becomes productive, producing sputum, maybe yellowish or rusty colored, general malaise, maybe pleuritic chest pain, sharp pain with breathing, and dyspnea. On physical exam, listening over the affected area might reveal signs of consolidation, crackles, rales, bronchial breath sounds, harsher sounds heard where you should hear soft vesicular sounds, increased tactile fremitus, vibration felt when the patient speaks, and egophony, where E sounds like I. Diagnosis relies on this clinical picture, an elevated white blood cell count, and crucially, a chest X-ray showing infiltrates or consolidation. Identifying the specific pathogen, often via sputum culture or newer molecular tests, is really important for guiding antibiotic therapy in bacterial cases. Treatment involves ensuring adequate oxygenation, hydration, pulmonary hygiene, like encouraging coughing, and prompt appropriate antibiotics for bacterial pneumonia or sometimes antivirals for severe influenza.
Let's talk about tuberculosis. TB is still a massive global health problem. What makes Mycobacterium tuberculosis so difficult?
TB is caused by Mycobacterium tuberculosis, an acid-fast bacillus. It's highly contagious, spread through airborne droplets, produced when someone with active pulmonary TB coughs or sneezes. What makes it tricky is that in most people with healthy immune systems who get infected, the immune response doesn't eliminate the bacteria but contains it. This is called latent TB infection, LTBI.
How does the body contain it?
When the inhaled bacilli lodge in the lungs, usually the alveoli, they cause a localized inflammation, pneumonitis. Macrophages and neutrophils engulf the bacilli, but M. tuberculosis has ways to survive and even multiply inside macrophages. The immune system then walls off the infected area by forming a granuloma, a collection of immune cells called a tubercle. Over time, the infected tissue in the center of the tubercle dies off, forming a cheese-like material called caseation necrosis. A fibrous scar tissue capsule then forms around the tubercle, isolating the bacilli. These bacilli can remain dormant but viable within the tubercle for decades, even a lifetime. The person has LTBI infected but not sick and not contagious, but if their immune system weakens later in life due to HIV, malnutrition, cancer, immunosuppressive drugs, the bacilli can break out, multiply, and cause active progressive TB disease. This is reactivation TB.
So what does active TB look like clinically?
LTBI is asymptomatic. Active pulmonary TB usually develops gradually. Early symptoms are often vague. Fatigue, weight loss, lethargy, loss of appetite, maybe a low-grade fever that often peaks in the afternoon. A cough develops, initially dry, then becoming productive, often worsening over weeks or months. Night sweats are very characteristic. As the disease progresses, people may experience anxiety, dyspnea, chest pain, and sometimes hemoptysis, coughing up blood, if a blood vessel is eroded.
How is it diagnosed and treated?
Screening for infection usually involves either a tuberculin skin test, TST, or an interferon gamma release assay, IGRA, blood test. These detect an immune response to TB, indicating either LTBI or active disease. To diagnose active disease, you need confirmation, typically through identifying the acid-fast bacilli in a sputum smear under a microscope, growing the bacteria in culture, which takes weeks, and seeing characteristic findings like infiltrates or cavities on a chest X-ray. Treatment of active TB requires a long course, usually at least 6 months, of combination antibiotic therapy with multiple drugs to prevent resistance. Patients with active pulmonary TB need respiratory isolation initially until their sputum is confirmed non-infectious. Treating LTBI with a shorter course of antibiotics can prevent progression to active disease. Multi-drug-resistant TB, MDR-TB, is a major challenge, requiring longer treatment with more toxic second-line drugs.
The chapter also mentions abscess formation and cavitation. Briefly, what's that?
A lung abscess is basically a localized area of pus formation and necrosis, tissue death, within the lung parenchyma. It's often caused by aspiration of bacteria, particularly anaerobic bacteria from the mouth, especially in people with risk factors like alcohol abuse or poor dentition. As the infected tissue breaks down necrosis, it can form a cavity. If this cavity connects with a bronchus, the abscess can drain, leading to the person suddenly coughing up large amounts of often foul-smelling, purulent sputum. Hemoptysis can also occur. Symptoms are typically fever, cough, chills, and pleural pain. Treatment involves long courses of antibiotics and sometimes chest physical therapy or drainage procedures.
Okay, moving to the final major section, pulmonary vascular disease. This is about the blood flow through the lungs.
Exactly. These disorders disrupt blood flow by occluding vessels, like clots, increasing the resistance within the pulmonary vascular bed, or destroying parts of the vascular network itself. This leads to significant V-Shuch imbalances and can severely strain the right side of the heart. We'll cover pulmonary embolism, pulmonary hypertension, and cor pulmonale.
Pulmonary embolism, PE, this seems like a critical one to understand.
Absolutely. PE is the blockage of a portion of the pulmonary artery system by an embolus, a traveling mass. By far the most common embolus is a blood clot, thrombus, that originates in the deep veins of the legs or pelvis, the deep venous thrombosis, DVT. When a piece breaks off and travels to the lungs, that's PE. The whole process is often called venous thromboembolism, VTE. Risk factors fall into Virchow's triad: venous stasis from immobility, surgery, heart failure, endothelial injury from trauma, surgery, infection, and hypercoagulability from inherited disorders, cancer, pregnancy, hormone therapy. Less commonly, emboli can be composed of fat, air, tumor cells, or foreign material.
What happens physiologically when an embolus lodges in the pulmonary artery? Figure 29.17.
Right, figure 29.17 outlines the pathogenesis. The consequences depend on the size of the embolus and the patient's underlying cardiopulmonary status. Even small emboli block blood flow to downstream capillaries, creating alveolar dead space, ventilated but not perfused, leading to V-Shuch mismatch and hypoxemia. They might also cause inflammation. Larger emboli can cause infarction, tissue death, in a segment of the lung if collateral circulation isn't adequate. Massive PEs can acutely obstruct a large portion of the pulmonary circulation, drastically increasing pulmonary artery pressure and causing profound shock. Significant obstruction also triggers reflex pulmonary artery vasoconstriction, further increasing pulmonary hypertension and putting an immense acute workload on the right ventricle, potentially leading to acute right heart failure and circulatory collapse.
What are the classic signs someone might have a PE?
They're often frustratingly nonspecific, making PE hard to diagnose. But the classic presentation is the sudden onset of pleuritic chest pain, sharp, worse with breathing, dyspnea, tachypnea, rapid breathing, tachycardia, rapid heart rate, and often unexplained anxiety or apprehension. A massive PE presents with severe symptoms: profound dyspnea, central chest pain, shock, hypotension, poor perfusion, and potentially syncope or cardiac arrest.
How is it diagnosed and managed?
Diagnosis often starts with assessing clinical probability, then tests like D-dimer, a blood test that's sensitive but not specific. Imaging is key. CT pulmonary angiography, CTPA, is now the primary diagnostic tool. Ventilation perfusion VQ scans are an alternative. Prevention in high-risk individuals, like post-op patients, is crucial, using mechanical methods like compression stockings or devices, encouraging early ambulation, and giving prophylactic anticoagulant medication. Treatment for confirmed PE is primarily anticoagulation, like heparin initially, then warfarin or newer oral anticoagulants, to prevent further clots and allow the body to break down the existing one. For massive life-threatening PEs, fibrinolytic, clot-busting drugs, or even surgical embolectomy might be necessary.
Next, pulmonary arterial hypertension, PAH. This is high blood pressure specifically in the pulmonary arteries.
Yes. PAH is defined hemodynamically as a mean pulmonary artery pressure greater than 25 millimeter Hg measured at rest during right heart catheterization. There are many causes and types, but many share common pathologic features. Endothelial dysfunction, the inner lining of the vessels doesn't work properly, leading to an imbalance with too many vasoconstrictors, like endothelin produced, and not enough vasodilators, like nitric oxide, prostacyclin. This, along with inflammation and other factors, leads to proliferation of cells within the vessel walls, fibrosis, and thickening, collectively called vascular remodeling. This narrows the small pulmonary arterioles and makes them constrict abnormally. The result is increased pulmonary vascular resistance. The right ventricle has to pump against this higher resistance, which increases its workload dramatically, leading to right ventricular hypertrophy and eventually failure cor pulmonale. Figure 29.0 shows this pathway nicely: how underlying lung disease or hypoxemia causes vasoconstriction and remodeling, increasing PAP, leading to RV hypertrophy and failure.
So what does this feel like for the patient? How does it manifest?
PAH often develops insidiously and goes undetected until it's quite advanced. Early signs might just be subtle changes on an ECG suggesting right ventricular hypertrophy or an enlarged right heart seen on a chest X-ray. The first symptoms are often nonspecific: fatigue, maybe some chest discomfort, tachypnea, and dyspnea, especially with exertion. As it progresses and the right ventricle starts to fail, signs of systemic venous congestion appear. Jugular venous distension in the neck, peripheral edema, swelling in the legs and ankles, sometimes enlarged liver or spleen.
How is it diagnosed and treated?
While suspected based on symptoms, echocardiogram, and other tests, the definitive diagnosis requires right heart catheterization to directly measure the pressures. Treatment involves addressing any underlying cause if possible, like treating underlying lung disease or sleep apnea. General measures include supplemental oxygen if hypoxemic, diuretics for fluid overload, sometimes anticoagulation. Avoiding things that worsen it, like high altitude, is important. There are also specific PAH medications that target the abnormal pathways drugs that promote vasodilation, like prostacyclins, PDE5 inhibitors, endothelin receptor antagonists. These can improve symptoms and slow progression, but unfortunately, none are curative. For severe, refractory PAH, lung transplantation may be the only option.
And that leads directly to pulmonale. You've mentioned it's basically right heart failure caused by lung disease.
Precisely. Pulmonale is defined as right ventricular enlargement, either hypertrophy, thickening of the muscle, or dilation, stretching out of the chamber, or both, that is secondary to pulmonary hypertension caused by diseases of the lungs, pleura, chest wall, or pulmonary circulation. It's heart disease resulting from lung disease. The chronic pressure overload from PAH makes the normally thin-walled, low-pressure right ventricle work much harder. Initially, it compensates by hypertrophy, but eventually it can't keep up, starts to dilate, and its pumping function fails.
What are the key clinical signs that point specifically to pulmonale?
Symptoms might initially be subtle, perhaps only appearing during exercise stress testing. The ECG might show signs of right ventricular hypertrophy. As right heart failure develops, you see those signs of systemic venous congestion we mentioned, distended neck veins, jugular venous distension, hepatosplenomegaly, enlarged liver and spleen due to congestion, and peripheral edema. Ascites, fluid in the abdomen, can occur in severe cases. Treatment fundamentally focuses on decreasing the workload of the right ventricle. This means managing the underlying pulmonary hypertension and the lung disease causing it. Treating the lung disease is treating the core pulmonale.
Finally, we need to cover the sobering topic of malignancies of the respiratory tract, starting with laryngeal cancer.
Right, cancer of the larynx or voice box. It's relatively uncommon compared to lung cancer, significantly more frequent in men than women, and has a very strong association with tobacco smoking. The risk is even higher when smoking is combined with heavy alcohol consumption. Human papillomavirus, HPV infection, is also emerging as a risk factor, particularly for certain types.
What are the warning signs?
The most common presenting symptom, especially for tumors on the true vocal cords, glottic cancer, which is the most frequent type, is hoarseness. Any persistent hoarseness really needs evaluation. Other symptoms can include dyspnea if the tumor obstructs the airway, and cough. Progressive hoarseness can eventually lead to complete voice loss.
How is it diagnosed and treated?
Diagnosis is made by visualizing the larynx with laryngoscopy and taking a biopsy of any suspicious lesion. Treatment depends on the stage and location, but can involve radiation therapy, chemotherapy, surgical resection, or often combinations. There's a strong emphasis now on larynx preservation strategies whenever possible.
And now the big one, lung cancer, a leading cause of cancer death.
Sadly, yes. Lung cancer, also called bronchogenic carcinoma because most arise from the epithelium of the respiratory tract, bronchi, is the leading cause of cancer deaths for both men and women. And the link to cigarette smoking is overwhelmingly responsible for nearly 80% of cases. But other risk factors exist: environmental tobacco smoke, secondhand smoke, occupational exposures, asbestos, radon gas, radiation exposure, air pollution, and certain genetic predispositions.
How are lung cancers categorized? Table 29.3 gives an overview.
Broadly, they're divided into two major groups based on their appearance under the microscope, which also reflects their biology and treatment approaches: non-small cell lung carcinoma, NSCLC, and neuroendocrine tumors, the most common of which is small cell lung carcinoma, SCLC. Table 29.3 highlights key differences in growth rate, metastasis patterns, and typical manifestations. NSCLC makes up the vast majority, about 85%.
Let's quickly touch on the main NSCLC types. Figure 29.2 shows some visuals. Squamous cell carcinoma. accounts for about 30% of bronchogenic cancers. Typically arises centrally, near the main bronchi or HeLa. Often presents with symptoms related to airway irritation or obstruction, like a non-productive cough or hemoptysis. Pneumonia or atelectasis occurring behind the tumor blockage are common. Figure 29.20a shows a typical Hiller tumor. It tends to grow locally for a while before metastasizing late. Adenocarcinoma. This is now the most common type, around 35–40%. It usually arises in the periphery of the lung. It may be asymptomatic for a long time or present with symptoms related to pleural involvement like pleuritic chest pain. It develops through a known stepwise progression from atypical cells to invasive cancer. Figure 29.20b shows a peripheral adenocarcinoma nodule, large cell carcinoma, a less common type, maybe 10%. These are undifferentiated tumors, often large, can arise centrally or peripherally, and have a tendency for rapid growth and early widespread metastasis. And the other major category, small cell lung carcinoma, SCLC.
SCLC accounts for about 15–20% of lung cancers. It's a distinct entity arising from neuroendocrine precursor cells in the bronchial epithelium. It's characterized by very rapid growth, a strong association with smoking, and critically, early and widespread metastasis. By the time it's diagnosed, it is often already spread extensively. Figure 29.2cc shows how it can appear as multiple confluent nodules.
And SCLC has that really interesting connection to ectopic hormone production.
Yes, that's a key feature. SCLC cells often retain their neuroendocrine ability to produce hormones or hormone-like substances that they shouldn't be making. This leads to perineoplastic syndromes. Examples include producing ADH, antidiuretic hormone, causing hyponatremia, low sodium, ACTH, causing Cushing's syndrome, or calcitonin, causing hypocalcemia. Sometimes these perineoplastic symptoms, the effects of the ectopic hormones, are actually the first signs that bring the patient to medical attention, even before any lung symptoms are obvious. It's a crucial clinical clue. Pathophysiologically, lung cancer develops through a multi-step process involving accumulation of genetic mutations, often initiated by carcinogens in tobacco smoke, acting on a background of genetic susceptibility. Tumor development is then promoted by growth factors and chronic inflammation. Epithelial cells undergo changes from metaplasia, change in cell type, to dysplasia, abnormal cells, to carcinoma in situ, cancer confined to the surface layer, and finally invasive carcinoma, with the potential for invasion into surrounding tissues and metastasis to distant sites via blood or lymphatics.
What about evaluation and treatment? How is it approached?
Early detection is key but difficult. Annual screening with low-dose CT scans is now recommended for certain high-risk individuals, heavy smokers in a specific age range. Diagnosis involves various methods. Sputum cytology, looking for cancer cells in coughed-up sputum. Imaging, chest X-ray, CT, PT scans, bronchoscopy, camera down the airways, with biopsies, or needle biopsies guided by imaging. Getting tissue is crucial to determine the exact cell type and, increasingly, the tumor's molecular characteristics. Staging determining the extent of spread is critical for treatment planning, and SCLC uses the TNM tumor node metastasis system. SCLC is often staged more simply as limited stage, confined to one side of the chest, or extensive stage, spread beyond that. Treatment depends heavily on the cell type, stage, the patient's overall health, and now specific genetic mutations within the tumor. For early-stage NSCLC, surgical resection offers the best chance of cure. For more advanced NSCLC or metastatic disease, options include chemotherapy, radiation therapy, targeted therapies aimed at specific mutations like EGFR or ALK inhibitors, and immunotherapy. SCLC is usually treated with chemotherapy, often combined with radiation, as it's typically widespread at diagnosis. Surgery is rarely an option. The Did You Know box on molecular and immune therapies highlights some really exciting advances. Targeted therapies, like tyrosine kinase inhibitors, can be highly effective if the tumor has the right mutation. And immunotherapies, particularly checkpoint inhibitors like nivolumab or pembrolizumab, work by basically taking the brakes off the patient's own immune system, blocking signals like PD-1, PD-L1 that cancer cells use to hide, allowing T cells to recognize and attack the cancer. These have significantly improved outcomes for some patients with advanced lung cancer, although they are still rarely curative.
Wow, that was an incredibly comprehensive deep dive into pulmonary alterations. We've covered so much ground, from symptoms like dyspnea and cough to the mechanics of gas exchange failure and hypercapnia and hypoxemia.
We did. We also explored chest wall and pleural issues like pneumothorax, unpacked restrictive diseases like aspiration, atelectasis, and fibrosis, and contrasted them with obstructive conditions, asthma, chronic bronchitis, emphysema, highlighting those different challenges to airflow.
And then we covered infections from acute bronchitis to TB, the serious vascular issues like PE and pulmonary hypertension leading to cor pulmonale, and finally, respiratory cancers, distinguishing laryngeal and lung cancers and touching on those exciting new therapies.
Understanding these alterations is absolutely fundamental. It's the bedrock for diagnosing and managing respiratory illness. You really see the intricate interplay of physiology and pathology defining health and disease in the system.
So what does this all mean for you, our listener? Hopefully, it means you now have a much clearer understanding of how even subtle breathing changes can signal significant underlying problems and just how connected our body systems are. It's a really powerful foundation, whether you're heading into health sciences or just want to be better informed.
We definitely encourage you to maybe pick one concept from today that really stood out or surprised you. Mull it over. How might that piece of knowledge change how you think about something as basic as breathing?
Thank you so much for joining us on this deep dive. We hope it sparks some aha moments and clarified these crucial concepts. A huge thank you, as always, to the Last Minute Lecture team for making this possible. Until next time, keep digging, keep learning, and keep being curious.